Welcome everybody to the third webinar in our community of practice for hepatitis C care in regional and remote Australia. My name's Nikita Habraka and I'm the Director of Programs here at INSU. It's my great pleasure to welcome you to the webinar, and I'd now like to hand you over to our webinar hosts, Alex Wade and Peter Garver. Over to you, Alex and Peter.
Thanks, Nikita. So my name is Alex and I am a clinical nurse consultant from the Mid-North Coast. If people don't know who I am, and I'd like to welcome you also, and to just send out an acknowledgement of the country that you might be sitting on. Today, I'm actually sitting on Indonesian land in the lovely island of Java. And I would like to acknowledge the knowledge and tradition of the lands I'm on, but also the lands that you're all sitting on today, and how important it is that in Australia particularly, that the lands were never ceded, they were taken, and that we continue to work toward finding some better solutions for health amongst our Indigenous community, especially in this space that we're talking about with hepatitis C care. So, thank you.
Hi everyone, I'm Peter. I'm a lived experience peer worker here at Peer Based Harm Reduction WA. Anytime we are talking about health and harm reduction, it's important to recognise the voices and the contribution of people with lived and living experience. We recognise the importance of supporting the growth and leadership of our lived and living experience workforce. We remember those we have lost. We pay tribute to everyone who has paved the way, those with us now and those yet to come.
That's us.
That's us.
Okay, so just those basic, webinar housekeeping things. If you can keep your microphone on mute when you're speaking. Also, please feel free to use the chat function. If you have any questions you want to ask throughout, just put them in there and I'll keep an eye on that. It's really nice to be able to see people, especially for the speaker, because it's like having an audience, and you can, if you feel comfortable enough or in your space where you can, please keep your camera on. And also this is a safe space, and so we respect diverse experiences and also perspectives. And if you do have any technical issues, which always arise, please just drop a chat in the chat function and we'll see if we can, well, we being Nikita and Liv, actually. Peter and I will ignore that, but we'll hopefully be able to help you out. So the community of practice. All good? Yes. The community of practice is the 6 webinars that we've had across the year. This is our 3rd webinar, as Nikita mentioned. And we'll have the email series in between each webinar profiling different innovative models of care for Hep C in regional and remote Australia. Why regional and remote Australia? Because it's a different game. Out in the boondocks was more thought, and they're wider communities, people are spaced out, there's less resources. So we really try to dig deep to find out what other people are doing and what works in that space. And also, while each webinar has a topic or a theme, we're really open to hearing what people need to talk about. If they are wanting to connect, chat, share their experiences with each other in between too, it's a welcoming space and an email space as well. So if you would like to have, sorry, I missed that, Nikita, what's that last bit? If you'd like to have your regional or remote service or program profiled in the email series, please email us. We'd love to do that. Thank you. And these are where we're up to. So we can see webinar 3, we're up to today, and then we'll be moving on with in September, November and December with the last 3 webinar series, which you can read there. So please let us know if you'd like to be profiled.
Okay, and here is today's agenda. It's a loose agenda, as Alex has already explained. We'll just see where the conversation takes us. We're going to hear from Nikki May from Quinn in Queensland about integrated care for hepatitis C. and then we'll have some time for questions and an informal discussion. So without further ado, I would like to introduce our speaker, Nikki May. Nikki is a harm reduction coordinator at Quinn in Queensland. Take it away, Nikki.
Good morning. Thank you for having me. So I'm up in Garranville Borough, which is Townsville, so North Queensland. The slides I'm going to be showing today is going to be talking about Kelkadoonland, which is Mount Isa, so further inland, which again is, as discussed, a whole different ball game compared to Townsville. I'll just try and work out my screening. Okay, I think that should be working now. As ASHA mapping shows, the northwest area of Queensland has about a 17% higher prevalence of Hep C compared to the rest of the nation, but also a lower uptake of treatment and testing. So between 2023 and 2024, Quinn had the privilege of going out for 18 months doing what we called FIFO-style clinics. We did lovingly name them PAG, so prick and go, because we'd fly in, prick some fingers and fly back out every month. So the team was Mary, the nurse practitioner, and myself as a harm reduction worker, and we would fly out for 3 days each month, and we'd be doing point-of-care testing for Hep C, HIV antibody antigen, as well as syphilis antibodies as well. On top of that, we were doing harm reduction support, some drug intervention stuff, and upskilling local staff as well in their AOD areas. So it was a fun morning flying out. I think it was a 6 a.m. flight on Qantas to fly to Mount Isa, and I would have a carry case in my carry-on with an injecting arm and a vein light on it. So safe to say I got security screened most months that I went through. So the secondary part of this project for the 18 months was working alongside the local services, so upskilling them in their Hep C education, so further screening questions, but also Quinn couldn't keep going in forever, so we wanted to establish a local network of services that were going to form their own referral pathways for testing and treating as well. So during those 18 months, we had about 224 people attend our clinics where they were tested for Hep C. There was some HIV and syphilis testing on top of that. So we found 5 positives during that time. So HCV detected. We were also able to, on top of that, do 7 SVR tests for people that had been previously incarcerated and were treated in incarceration and never had follow-up testing in community. So we were able to confirm that they cleared that virus for them. And we had 17 syphilis antibody positives where we were able to collaborate with the North Queensland Syphilis Service as well as Mount Isa Sexual Health to get them on for further pathology and treating follow-ups. So it was really great. We were welcomed into 10 different testing locations as well. So we tested across Mount Isa AODS, the Sexual Health Team, Gidgee Healing, which is the Aboriginal and Torres Strait Islander Health Service. We were welcomed into the Mount Isa Watch House too, which was a massive feat. The Riverbed Outreach Group, the Northwest Indigenous Catholic Social Services, the Arthur Peterson Diversionary Centre, the Brilla Brilla Community Centre, the St. Vincent de Paul's Men Hostel. We tested at the Rodeo Street Festival for the opening week of rodeo. So I got to test people while Dale Braithwaite was singing Horses live up the street. And then we were also offering home visits on top of that as well. So while we were physically testing from these Mount Isa locations, many people being tested actually came from even more remote areas. So we had people from Cloncurry, Doomadgee, Mornington Islands, Normanton, Corumba, and even across the border of Northern Territory coming from Tennant Creek. So it was quite a diverse group of people who hadn't heard about safe injecting practices, who didn't know about Hep C testing. A fair few people were coming in and out of incarceration where they were safe enough to disclose that that's where they've learned their injecting practices from. So we're able to do a lot of that health and harm reduction intervention during these tests as well. It was just really great. It was a really opening and welcoming community. Everyone was really interested in Hep C and the testing and what we were doing there. So it was really great just to be welcomed in and having that great response. On top of that, we were going through some local services. So we worked alongside AODS. We worked with some community centres and just doing some basic drug intervention work with their workers. So what people might, dispelling some of that fear that people have working alongside people who use drugs, particularly those injecting. Don't assume that everyone's on drugs. There may be mental health and other involvement as well. So we're able to do just that basic AOD upskilling and staff too. So we had a really welcoming reception from community. And I think what worked well is that we went to community. So we jumped in a car, we travelled around. We didn't sit inside one service and wait for people to come to us. We were just trying to find as many spots as we could to go to people. So we would just sit and we'd have a chat. We found that showing up in casual clothes, like we didn't wear uniforms, we would just show up in casual clothes. We just have our testing equipment out, and people would come to us and be like, "Oh, what are you doing? What's this? Who are you guys?" And just going, "Oh, we're here. We're doing finger prick tests. We can test you for Hep C. We can do syphilis and HIV antibodies too. Like, if you're interested, sit down and have a chat." That's how we bagged most people in. There wasn't a real fear around I'm getting tested for Hep C. We found a lot of the chat we had, people had Hep C concerns in the past, but they didn't want to be seen going to their doctor. They didn't want to be seen going to an AOD service. There was a lot of fear around small town gossip as well, but also concerns around their own confidentiality. You know, auntie works at the health centre and I don't want to go in there just in case she finds out that I'm asking for a Hep C test. So being able to go out into community, into a bit more open, discreet areas, people could come to us. Unless someone else was getting tested, they didn't really know what we were there for. So people felt they had a bit more confidentiality and safety in that point of care testing style. The other thing that worked for us really well too is being an NGO, and I pre-apologise to any government health workers out there, but I found as soon as you say you're a non-government service, people are definitely a lot more receptive to wanting to sit and chat and find out what you're doing. But also incentives, we incentivize. So on a local level, we do $20 Coles gift card vouchers for anyone coming through for Hep C testing. In Mount Isa, we were offering other incentives. It was some days just snack packs, so like a whole bunch of little snacky foods in a bag. What went over really well? Free thongs. We just went to the cheap shop and bulked up on pairs of thongs, and like the NRL team ones, they flew out of the basket. Everyone wanted a Hep C test, even if they weren't concerned, because they just wanted the NRL thongs. And it was great. It got so much engagement going and just a whole lot of chatting as well. And it opened up to all sorts of chats. Those were really, if you can, bulk up on free thongs. That'll get people in. But also just the services wanting to help us out and work together. We would pre-send out our dates that we would come out each month. The services would share them, chat with their clients. And so we would have people already lined up for us when we landed and got there. So that really collaborative, supportive style of people working together instead of being in their own silos really opened up a lot of opportunities and like cross-communication, cross-working, and just really great collaboration. So part of that secondary side of what we were doing with our local referral pathways, we facilitated a number of workshops with local services, getting together, having an open chat about the lack of testing and treating that was happening and what some of these barriers might be coming up. So there was a fair few talking points that came up. The biggest one was discussing the fact that people who use drugs still face a lot of stigma and discrimination these days. It's not having a safe access point. And when we talk about safety, it's not just in AOD, it's everywhere else. It's accessing a community centre, and maybe they don't feel like they can ask for support because it's, okay, you know, well, you need to stop using drugs if you want our support. And Hep C and any kind of support for people who use the substances shouldn't be contingent on if they're going to be willing to stop or reduce or anything like that. So having those chats that you are very much within your rights to access Hep C support, regardless of what your using status is, that was a massive chat that we had to have with a lot of services as well. So on top of that, it was just, you know, they don't want to have to rely on GPs all the time and pathology. And again, pathology doesn't always work for testing. If you have people that have really bad vein access, that's going to be a massive barrier. So the fact that we could come in and do it through a finger prick test, we would have the results the same day. They don't have to come back 2 weeks later to their doctor was a massive thing that the community was loving as well. People saw it as like a little science experiment. You'd do their finger prick and they'd see their blood go on the test and the results come through, and that was a big fascination in itself. So being able to sit there and people see what's happening with their blood, with their tests and their results was a big barrier reducer as well. So again, just that small town gossip, people concerned about their safety, that came up as a lot of barriers. So being able to have so many services in one space, having these open chats meant that even though we were coming up to these barriers, we were addressing in knowledge, it let us see that there was also this list of services that want to break down these barriers and overcome them, and how to work best with community. And that's really what we were looking for, because it meant that we had that really great collaborative going on. So through these workshops, it was developed and proposed that Mount Isa AODS would be the home base for a gene expert machine, as well as antibody testing access for Hep C. And they would take the lead in the maintenance as part of the Kirby Flinders Hep C testing project. So they'd take on all the compliance and the maintenance that was needed. But they would also co-collaborate with sexual health as one of the other major stakeholders involved. So this collaboration would then be supported by Gidgee Healing, the Riverbed Outreach team, and the nursing team who manages all the medical needs within the Watch House. So they were kind of our really big key stakeholders that were willing to collaborate and get together on this project. We then had some other services come through, so like probation parole as well, but we found a lot of the community centres came together and were really happy to offer their locations for free testing service spaces as well. So anytime any of the key services involved wanted to go out and do that on the ground community, these community centres were happy to offer up their spaces, their outdoor areas, whatever they needed, so that community members could come through and access them. So this testing pathway was going to then get linked back to the Mount Isa AODS nurse practitioner for scripting. We found another barrier was finding a GP who was willing to commit the time to scripting and ongoing care on the medical side as well. So having a in-house nurse practitioner and it being nurse practitioner-led scripting was a really great barrier to overcome and being overseen by AODS. There are still some continued barriers though. So while this wrapped up back in 2024, it's taken nearly 2 years for the HHS service to actually approve AODS having their machine or the policies and procedures that went with it. So they only received all their approvals 3 weeks ago. So that was really disheartening to see that even though everything was put together, laid out in place, we thought we would overcome these barriers, it's still taken another 2 years to actually get it up off the ground. So because of this delay, there's been a loss in community engagement in Hep C testing in general, just also due not to having point of care available. So it's gone back to people having to be screened by their GPs and getting pathology requests. Also, just the fact that rural and remote outreach areas tend to have higher rates of staff turnover. It's a lot of locums, temporary contracts, high burnouts. It's just those areas where there's not a lot of long-term sustainable staff. Means that staff who were trained through Kirby and Flinders to provide point of care testing have since left. So now it's recruiting and retraining more staff. So again, that causes delay in being able to actually get out boots on the ground kind of technique because it's having to wait for the compliance side. So this has ended up in a bit of a loss of momentum. So loss of people getting out and talking about Hep C regularly. Lost a lot of that rapport with community too. They were used to seeing us come out once a month. People knew where we were going to be. It built a lot of rapport and that reliability that they could just drop by and chat. Now that that's died back because of all of these delays, a lot of that's died as well. Another thing that sort of doesn't get talked about a whole lot is the lack of primary NSP access as well. So there are very minimal primary NSPs in the north of Queensland. So because primary NSPs can often take on that extra role of that Hep C testing and treating, like it is part of our main program, this now falls onto secondary NSP services, but also secondary other services. Everyone's already overworked as it is, so now having to put that back onto AODS and sexual health because there isn't a primary NSP to pick that up is going to add to their caseload as well. So really advocating for having more primary NSP access, just for safe NSP access in general as well. Just for a bit of a layout sort of view, people in the northern areas like Dulmagine and Mornington Island, their closest NSP access is Mount Isa. So that's approximately maybe a 10-hour drive, I believe, or they can shoot across to the coast to Cairns and Townsville. So that whole side of prevention as well is what's really lacking, and it's going to really make it harder to get hepatitis reduced by 2030. Hopefully over time, these might be talked about more. These barriers can be overcome. Now that the HHS has approved everything, that should get all the momentum back up and running. But that's pretty much everything. I hope I covered it all. I love seeing what the teams do out that way, and I'm really looking forward to seeing what they can do now that they have their gene expert machine they can really get that up on the ground. Ruth, who oversees AODS out there, she's absolute champion, and I'm really excited to see what she can pick back up. Our contact details too, if anyone ever wants